Right ventricular pacing restores an adequate heart rate in patients with AV block, of course, but we know that high percentages of patients with right ventricular apical pacing develop left ventricular systolic dysfunction. Now in the New England Journal of Medicine, researchers report whether BiV pacing might reduce mortality, morbidity, and adverse left ventricular remodeling in such patients. This randomized study enrolled patients who had an AV block, varying degrees of heart failure, and a left ventricular ejection fraction of 50% or less, not normal. Patients received a cardiac resynchronization pacer and were randomly assigned to standard right ventricular pacing or BiV pacing. The primary outcome was the time to death from any cause, an urgent care visit for heart failure that required IV therapy, or a 15% or more increase in left ventricular end systolic volume index. Almost 700 patients underwent randomization and were followed for an average of 3 years. 56% of patients in the RV pacing group had an outcome, as compared to only 46% in the BiV pacing group, a significant difference with a hazard ratio of about 0.7. If you think about it, BiV pacing must have had some downside from placing a left ventricular lead, and sure enough, left ventricular lead-related complications occurred in about 6% of patients. So those are the data. What do we learn from this study? BiV pacing seems to be superior to conventional right ventricular pacing in patients with heart block and a wide range of left ventricular systolic dysfunction with New York Heart Class 1, 2, or 3 heart failure. In addition, this study adds to the body of evidence suggesting that BiV pacing in patients with heart block preserves systolic function. And here's the really important part. These patients did not have an established indication for BiV pacing, which raises the issue of whether we should consider moving to BiV pacing exclusively in patients with any abnormal ejection fraction. I'm Peter Block, and this is a CardioSource Heart Minute.